Dear friends, dear colleagues, welcome to today's EACVI webinar on highlights from the EuroEcho-Imaging 2018. I am Professor Tor Edvardsen from Oslo University Hospital, and I have the pleasure to be joined by Professor Ervan Donal from the Rennes University. Professor Bogdan Popescu was also supposed to join us, but his flights today were cancelled because of airport strikes in Germany. The aim of this seminar is to give you a snapshot of some of the best and latest imaging research that was presented at the EuroEcho-Imaging 2018. This session is highly interactive, and we strongly encourage you to actively participate by sending your questions, your comments at any time during the webinar through the chat. Now I will start the presentation and then I will hand over to Ervan. So EuroEcho-Imaging 2018 in Milan was a great success. We had 4,216 attendance there, so it was a new record. And a big congress like that makes it an ideal platform for networking. We had international audience from 98 different countries around the world. We had 118 scientific sessions. We had the latest research in imaging, 14 oral abstract sessions, 34 poster sessions. And there is a great opportunity to meet with all the key opinion leaders in cardiac imaging. We had 431 faculty members from 44 countries around the world. And we had also a record-breaking submissions number. We had more than 1,100 abstract submitted to the conference, and we had 557 clinical cases that were submitted for presentation in Milan. So during this session, Ervan and myself will present some of the best, but not all of them. It's impossible within 1 hour, but some of the best and recent scientific studies that were presented during EuroEcho-Imaging 2018. I'll start with some abstracts about myocardial function. And I would like to thank Doctors Christina Haugo, Muraru, Gimelli, Bucciarelli Ducci, Dahl, and Baruca for providing us the slides, and they had the live session in Milan, the highlight session there at Saturday, and went through all of the best abstracts from the conference. So the first I want to present to you is about what's happening after a ultra-marathon race, 246 kilometers of running. And these guys from Greek, they checked the all 4-chamber longitudinal strain assessment after 33 hours of running. Can you imagine 33 hours of continuously running, 246 kilometers ultramarathon? And they found that the function of the left ventricle and right ventricle was a little bit decreased after running such a long distance, but still within the normal ranges of strain. So, and they also had, they checked the concordance of the inter and atrioventricular concordance, and that was maintained after such a race. So they concluded, despite subtle changes in left ventricle and right ventricular strain, 4-chamber strain remained within normal range after ultramarathon, maintaining the inter and atrioventricular concordance. But I think you should think twice before you run such a long distance. Another study about athlete's heart, that was one of the main topics of the conference, was this one. It was a review from Siena. They went through all the English language studies in Medline when imaging CMR in athletes. And they could include 983 competitive athletes. And they checked left and right ventricle volumes according to how much you train. And they found that there is evidence of cardiac adaptation to exercise and how the duration of exercise. And at the right side here, you can see that if you are training more than 20 hours per week, you can see that the right ventricular end diastolic volume is bigger than if you train less here at the left side. This is an average of those who train less than 10 hours per week. And we had a feeling that it was a relationship between hours of training and cardiac size, but now here is the evidence. Another interesting study was to test the effect of right atrial pacing on left atrial function and structure. So the objective of this study from Genk in Belgium was to assess the impact of RA pacing on LA physiology in CRT patients. And they prospectively included heart failure with reduced ejection fraction patients, HFrEF, 36 patients with sinus rhythm undergoing CRT implant. And they analyzed LA strain rate and volumes at the implant and after 6 months with follow-up. And divided the patients into two subgroups according to RA pacing above or below mean. And the results was that chronic RA pacing was associated with deterioration of LA structure, reservoir and booster function. And that was probably mediated by intra-atrial dysynchrony. So that might sort of explain some of the symptoms that patients have after CRT implant. But this was a kind of small study with 36 patients, so it has to be tested again in a bigger study. Another study on right ventricular evaluation with conventional transthoracic echocardiography in patients with frequent premature ventricular contraction undergoing ablation was published from Barcelona in Spain. They included 50 patients that underwent PVC ablation. They probably had RVOT tachycardia, most of the patients. And they used two-dimensional RV assessment according to current EACVI recommendations. And they checked baseline before ablation and 6 months after ablation. And they defined responders to ablation had more than 80% reduction in PVCs. And as you can see in the table at the right side, those with successful ablation compared to those with non-successful ablation. And responders, they have reduction of RV right ventricular dimensions and also an increase in fractional area shortening. And they also had improved left ventricular ejection fraction. Those who were non-successful ablation, they had a worsening in right ventricular function. So they concluded that similar to left ventricle, frequent PVCs are associated with right ventricular remodeling, which can be reversed by successful ablation. Here's another study from Padua in Italy and Royal Brompton in London. And the first author, Dr. Surkova, has received an EACVI training and ESE research grant. They tested the relative importance of reduced left and right ventricular ejection fraction to predict prognosis in a large cohort of unselected patients with cardiac diseases. It was a three-dimensional echocardiographic study. So they tested approximately 400 patients that were sent to echocardiography, and they divided into 4 groups according to left ventricular ejection fraction, better than 50 and less than 50%, and right ventricular ejection fraction better than 45% or worse than 45%. So group 1 had the best performance, and then gradually going down to group 4 with the worst performance. And they followed the patients for almost 4 years, and they tested for outcome, all-cause mortality or cardiac death. And here are the results from that study. And you can see that, as expected, if you had a very low left ventricular, or a low ejection fraction at the left side, less than 50%, and a lower right ventricular ejection fraction, less than 45%, they had the highest mortality of all groups. This line here. And those with ejection fraction at the left side, better than 50%, and better right ventricular ejection fraction, better than 45%, they had the best prognosis. But the red line here is interesting because they have left ventricular ejection fraction less than 50%. But they do have intact right ventricular function. And they have really good prognosis if you follow the red lines on all-cause mortality and also cardiac death. So right ventricular function comes up as a very important predictor in people with cardiac disease. And here is the same theories in an even bigger study, a sort of a prognostic validation study, together with other hospitals as well, Padua and London and more. And they had the same ideas and tested in a validation cohort of 446 patients. And they also tested primary endpoint was cardiac death, and secondary endpoint was MACES, cardiac death, non-fatal MI, ventricular fibrillation, and heart failure exacerbation. And the results are the same, that the right ventricular function is the most important predictor when you do a 3D echocardiogram out of these patients, compared to all other measures of volume that they did. And this was a large validation study, underlining the importance of right ventricular ejection fraction. And here is the study that won the Young Investigator Award for Clinical Science. It was from Leuven in Belgium. And they were interested in myocardial shear waves. Shear waves has been used before to sort of be a surrogate measure for myocardial stiffness. And you have to use ultra-high frame rate echocardiography. And they wanted to test the differences in the myocardial shear waves between normal people and patients with cardiac amyloidosis. And they had groups according to age of 46 healthy volunteers and then 17 patients with cardiac amyloidosis. And here is their equipment, a high frame rate scanner at the left side, and then is an illustration of the data reconstruction. It's a lot of data and many hours of work. So the results were that shear wave propagation velocity was higher in amyloidosis than in normal people. And that indicates that people with amyloidosis have higher myocardial stiffness. And they also found that shear wave's propagation velocity after mitral valve closing was significantly higher in patients with increasing diastolic dysfunction. Here is another study from Oslo. It's how you can use echocardiographic deformation imaging in arrhythmogenic cardiomyopathy. It was together with the Utrecht University Hospital in Netherlands. Oslo included 80 patients and Utrecht included 80 patients, and then we had 160 patients, probands and mutation plus family members. And the objective was to validate and combine strain pattern recognition and a right ventricular mechanical dispersion as markers of ventricular arrhythmias in patients with arrhythmogenic cardiomyopathy. And the results were, if you can see at the left side, the upper part of the image, then you can see 3 types of strain. First, the normal one, type 1, and then type 2 with a small initial systolic stretch and a post-systolic shortening, and type 3 was an even bigger systolic stretch, almost all the systole, and then post-systolic shortening and a low systolic deformation. That was the Utrecht method as a risk predictor of arrhythmias. And B is the Oslo method, the mechanical dispersion. It's a heterogenic contraction pattern of the right ventricle. And the results were, if you combine both methods, that was incremental and better, and the association to ventricular arrhythmias improved if you combine the 2 methods. Now I hand over to you, Herman. You can continue.
Yes, but maybe we can have a few questions coming from the audience. Maybe one about the assessment of the right ventricle. Do you think that nowadays we should use the strain data for assessing the right ventricular function in our daily clinical practice? And what do you think about the 3D assessment of the right ventricular ejection fraction?
Well, to start with the last question, I think it sounds very promising. These studies, they really increase the impact of the right ventricular ejection fraction. I have to admit we don't use it by ourselves, but I guess we have to start very soon. And I think right ventricular strain method can be important especially in diseases with that affects the right ventricle, like arrhythmogenic cardiomyopathy. And then I think, as we also wrote in the last recommendation paper or expert consensus paper of arrhythmic cardiomyopathy, I think it's important to add to all the other parameters of right ventricle function. And as you perfectly well know, that echocardiography is to put pieces together and then end up with a conclusion. And I think strain is a good add-on for that.
So great clinical value of strain imaging for the LV, but also for the RV.
Yeah, I agree.
Okay, so maybe I can continue.
Sure, please.
The second main topic of the Milan Congress that we had in Milan a few weeks ago was the valvular heart diseases, and then I will try to present to you few of the main abstracts that have been presented during this Congress. So it's a real pleasure for me to discuss this science that was presented in Milan, and of course I want to deeply thank all the people that are on that slides who were involved in the highlight session that took place on Saturday at the end of the Milan Congress we had in December. So first, I would like to discuss the tricuspid regurgitation, because nowadays we care a lot about tricuspid regurgitation, and also we know that we have a lot of patients who have been implanted with a pacemaker, so it means that we have a lot of patients with a lead crossing the tricuspid valve to go into the right ventricle. We have this nice study performed in Israel looking retrospectively at more than 600 patients that were implanted with a RV lead. And the authors looked at the prevalence of tricuspid regurgitation and at the determinants of this tricuspid regurgitation and its severity. As you can see, the prevalence of severe tricuspid regurgitation in their population was about 10%, which is quite huge. And if we look at the predictors of the degree of severity of the tricuspid regurg, they were able to distinguish 6 parameters, and more parameters you have, greater might be the tricuspid regurg. So we can keep in mind the fact that tricuspid regurg are more frequent if you have a female gender, if you have a lack of atrioventricular synchrony, if you have an increase in pulmonary pressure, if you have some degree of mitral regurgitation, if you have a rheumatic mitral valve disease, and if you have a pacemaker for a long time, greater than 4.5 years. And as you can see, all these risk factors are non-lead risk factors, which means that you can have a severe tricuspid regurgitation when you have a pacemaker, and the risk factors that are associated with this risk of tricuspid regurgitation are not necessarily linked to the lead crossing the tricuspid valve. So this is a nice study. I would like now to discuss another one about tricuspid regurgitation. And the clinical value of that study is quite important because every week we have to discuss patients with severe tricuspid regurgitation, and we don't have in the guidelines clear parameters to define the best timing to send a patient for surgery when the tricuspid regurg is severe and perhaps symptomatic. So the authors looked at the value of cardiac magnetic resonance imaging to best quantify the right ventricular function and right ventricular size in this patient with a severe tricuspid regurgitation. So they focus prospectively on patients with a severe tricuspid regurgitation. So they did that in one center. It took quite a long time, and they were able to follow this patient for more than 2 years. These patients were treated by surgery because of the tricuspid regurgitation. As you can see on the slide, the tricuspid regurgitation was very severe. But maybe unfortunately, these patients were not only treated for the tricuspid regurgitation, they were also treated for a mitral valve disease or an aortic valve disease. So as you can see, all the patients were sent to surgery for a tricuspid valve surgery, but also for mitral or an aortic valve surgery. These patients were severe. As you can see, during the follow-up, 7 patients died and 4 were admitted for heart failure. And authors looked at clinical parameters, echo parameters, hemodynamic parameters, and cardiac magnetic resonance imaging parameters to define pre-operatively which are the parameters that are associated with the risk of event after surgery. And they come up with the fact that it seems that the best predictor of events or death after the surgery is the indexed right ventricular end diastolic volume. And thanks to the ROC curves, they come up with the cutoff value of 107 milliliter per meter square to define 2 groups of patients with a sensitivity and specificity around 80% to predict the risk of severe events after surgery. So this is quite interesting. This is a small population. This is not a perfectly homogeneous population, but still it's interesting to have a cutoff value to define the degree of RV dilatation that might be associated with a bad result of surgery when a patient has a severe tricuspid regurg. So we can keep in mind that tricuspid regurgitation is a severe disease with a high risk of death and severe events even after surgery. We don't really know when we should send the patient for surgery. And thanks to that study, we might have to consider cardiac magnetic resonance imaging and the indexed right ventricular and diastolic volume to best define the timing for surgery. Let's move on now to the mitral regurg. So when we have to deal with a patient with a mitral regurg, when we have to assess the prognosis of a patient with a mitral regurg, we have to quantify this regurgitation. We have a recommendation paper coming from the EACVI to try to best quantify this mitral regurg. And thanks to this beautiful study that has been performed in Ghent University in Belgium, we have perhaps a new tool that we can consider. This new tool has been validated in animal studies, and the name is the average pixel intensity. The idea is just quite simple actually, to look at the continuous wave Doppler and to measure the pixel intensity of the continuous wave Doppler signal across the mitral valve during the regurgitation. And the authors were able to use this tool in the animal study and afterwards in a prospective study to validate this average pixel intensity parameter as a good prognostic marker in patients with a severe mitral regurgitation. So they did that clinical study prospectively looking for MACE or MACEs in patients with severe mitral regurgitation. And as you can see on that slide, according to the tertiles of average pixel intensity, they were able to distinguish 3 groups of patients who might have very different prognosis. And when they compare the prognostic value of the average pixel intensity against the vena contracta, against the effective regurgitant orifice area, or against the regurgitant volume, they were able to demonstrate that with a cutoff value of 111 units, the average pixel intensity was the best predictor of events in a population of severe mitral regurgitation. So this is a simple tool, just measuring the continuous wave Doppler across the mitral valve during the regurgitation, and it seems to work quite well to predict the risk of events. Let's discuss now still about the mitral valve, but not really about the regurgitation, but about the anatomy of the valve. And this beautiful study that has been done in Oslo looked at the mitral valve prolapse, but also looked at the mitral annulus disjunction. And looking at these patients with mitral valve prolapse and or mitral annulus disjunction, the authors looked for the risk of arrhythmic events according to the phenotype of the mitral valve disease. And they were able to nicely demonstrate that more important than the prolapse, the mitral annulus disjunction seems to be the most associated parameter with the risk of ventricular arrhythmia. So it's quite important to look at this mitral annulus disjunction to best characterize the mitral valve disease and perhaps to best predict the risk of severe ventricular arrhythmia. And in that study, when they compare patients with ventricular arrhythmia and patients without any ventricular arrhythmia, they were able to demonstrate that patients with ventricular arrhythmia are the ones who have the most fibrosis of the papillary muscle. They are the ones who have the less degree of mitral prolapse. They are the ones who have the most decrease in LV ejection fraction, even if the ejection fraction was quite normal. And these patients were younger than the one without any ventricular arrhythmias. So this is nice. And now we could move on to the aortic valve stenosis. Perhaps you think that we know everything about the aortic valve stenosis, and we quite know well how to deal with these patients. But that's not true actually. And even if we want to discuss about LV ejection fraction, we have guidelines, and in the guidelines it's written that you have to send an asymptomatic patient with a severe aortic valve stenosis to surgery if the LV ejection fraction is below 50%. These are the guidelines. But we have this nice study that has been performed in Belgium and France, looking at more than 1,600 patients with a severe aortic valve stenosis. These patients were all asymptomatic. They were all with an LV ejection fraction greater than 50%, and they were followed for more than 3 years. And authors looked at the risk of death according to the treatment, medical or surgical treatment. And they were able to demonstrate that instead of keeping in mind this cutoff value of 50%, perhaps we have to move on to 55%, because you can see that in the group of patients with an LV ejection fraction between 50 and 55, the risk of strong events is much higher than in patients with an LV ejection fraction greater than 55%. So the conclusion of that study is that LV ejection fraction should be measured very carefully in patients with a severe aortic stenosis when they are asymptomatic. This cutoff value of 50% should perhaps be moved to 55%, because it seems that between 50 and 55, the risk of strong events is quite high, and then patients should probably be sent to surgery before having a LV ejection fraction of 50%.
Thank you, Erwan. I think we have to stop there and discuss something. The last study was quite important. It was a big study saying actually that the current guideline is wrong.
Somehow.
Yeah, in a way, isn't it? Because those with 50%, they decrease, they go worse than those with 55. So do you think it's on time to change the current guidelines?
Actually, I think we have to think about this change, because we have this study demonstrating that, but there are other studies, one from the Mayo Clinic, one from Patricio Lancelotti in JAMA Cardiology, demonstrating exactly the same thing with cutoff value that might be even higher, around 60%. So I think that it's a strong message that we had in Milan thanks to that study, and perhaps we have ready to move on to 55 or 60% to consider this value as a normal value instead of 50.
Yeah, and you will return later in your talk also to aortic stenosis. So, and there are many questions coming up. There is one about pixel intensity study. That's post-processing, is it?
Yeah.
Okay. So if you adjust gain then, if you increase the gain, that's post-processing. What do you do? Does it affect the results?
So actually I was able to discuss with the guys who presented the study, and the fact is that for the study, the setting of the echo machine was fixed. So they were not able to move the gain, they were not able to change anything in the setting of the echo machine for all the study.
And here's also one asking about severe tricuspid regurgitation. Can you repair it transcutaneously?
That's a good question, but it's maybe too early to say that we can, because there are studies going on. The TriClip is not yet available commercially. So there are people who implant clips on the tricuspid valve, especially in Germany, but it's not yet validated for all the countries among Europe. So it's still something going on, and very promising actually. Okay,
so a last question then. What is the relation between ventricular arrhythmias and mitral valve prolapse?
The link between prolapse and arrhythmia is weak. as I showed you, it's more the disjunction than the prolapse who is associated with the risk of ventricular arrhythmia. And when you have a disjunction, you have more papillary muscle fibrosis. The phenotype of the disease is quite different, with a more decrease in LV ejection fraction, perhaps with less degree of regurgitation, so it's not exactly the same disease. So prolapse and mitral annulus disjunction are two different things.
So we have to look for both the prolapse and the MAD then?
Yes.
Okay, so please continue.
Thank you very much. And it's my pleasure now to discuss a bit about heart failure, because we had a lot of abstracts about heart failure. And first, I would like to discuss one CMR study looking at more than 1,160 myocardial infarction patients. All these patients were assessed using CMR, and authors look at myocardial deformation. They look at LV myocardial deformation, but also they looked at LA myocardial deformation. And they looked at the value of this deformation in this population of myocardial infarction. And they were able to demonstrate that LA reservoir function was identified as the strongest an independent predictor of MACE in this population. It has already been demonstrated with echo, but for the first time it's also demonstrated with cardiac MR. But the beauty of that study is perhaps the table on the right. As you can see, there is an independent prognostic value of LA reservoir function, but this LA reservoir function provide an incremental prognostic value for MACE to LV ejection fraction and to global longitudinal strain, which means that perhaps in our daily practice we should measure ejection fraction, GLS, and LA reservoir function in the population with a myocardial infarction. So atrial parameters are strong prognostic markers. It has been demonstrated by echo and it's confirmed by CMR, which is quite nice. Let's discuss now a Korean study, a huge Korean study looking at patients with non-obstructive coronary artery disease. This is quite a nice concept because authors looked at clinical data, biological data, imaging data, and they tried to build a score and to validate this score according to the prognosis and the risk of events. But more important than just looking at the value of an imaging tool or a clinical tool, they assess the value of their score according to the treatment. And you will see that it's quite interesting to apply maybe in our practice. So they look at a huge population of patients with a non-obstructive coronary artery disease. And in that patients, they got a lot of data, and thanks to these clinical, biological, and imaging data, they built a score integrating the age, the risk factors, the renal function, and the degree of atherosclerosis of the coronary artery disease. So they built the score, and of course they were able to demonstrate that higher is the score, worse is the prognosis, which makes sense. But more important than that, they were able to demonstrate that in patients with a high score, so high risk, if these patients were treated with statin, it decreased significantly the risk. In opposite to patients with a low score, so a low risk, if these patients were treated with aspirin, it increased the risk, which means that when you have a high score, you are at high risk. The fact that you have a statin treatment decreases your risk. If you have a low score, you have a low risk. If you are treated by aspirin, you increase your risk, which is quite variable. So this is a very nice study that has been performed according to coronary artery disease, non-obstructive coronary artery disease. And now we would like to discuss not about an abstract, but about a session that we had during the meeting. Because of course, EuroEcho-Imaging is a congress dedicated to science, to innovation, but also to teach us about the new things that we should apply in our daily clinical practice. And we would like to come back to aortic valve stenosis, because this is a huge topic, and we had the chance to have Tom Marwick, who was able to discuss about ejection fraction and the potential value of global longitudinal strain when we assess a patient with an aortic valve stenosis. So should we focus only on ejection fraction, or should we use really in our daily clinical practice the GLS? According to guidelines, we shouldn't use GLS. We just have to look at LV ejection fraction, and as we already discussed, in the guidelines, the cutoff value to decide to send a patient to surgery is 50% for the LV ejection fraction. But as we discussed already, we have several studies, among them the study from Tricuspid and colleagues in France and Belgium, demonstrating that perhaps this cutoff of 50 is too low, and we should consider, instead of 50, 55 or maybe 60% as the cutoff value to send or not a patient to surgery. So this is important to measure very precisely the LV ejection fraction, especially in patients who are asymptomatic with a severe aortic valve stenosis. This ejection fraction is strongly associated with the risk of event before but also after surgery. So everybody knows about ejection fraction. Everybody uses ejection fraction every day. We trust in ejection fraction, but perhaps ejection fraction should be reconsidered, measured more carefully, and the cutoff value of 50% is probably wrong. Let's discuss now about GLS. In favor of GLS, we have the fact that ejection fraction is not that reproducible. The cutoff value might be different according to the techniques. It's not the same if we consider 2D and 3D. It's not the same if we consider 2D echo and CMR. So ejection fraction is not that robust. GLS has been demonstrated thanks to the EACVI and the American Society of Echo Task Force as the most reproducible, the most robust tool that we have in echo. So we can use GLS in every single patient. It's easy to perform, it's reproducible, and it adds something to LV ejection fraction. It has been demonstrated in this nice study performed by the EACVI Research Committee and published by Julien Magne in EuroEcho-Imaging very recently. This is a meta-analysis performed about GLS in severe aortic valve stenosis patients, and these patients were all asymptomatic. And in that beautiful study, it has been demonstrated that you can predict the risk of death in asymptomatic patients with a cutoff value of 15%, and this is an independent prognostic marker. If you don't want to predict death, because it might be too late, you can predict also the risk of event. And it has been demonstrated nicely this year in JAMA Cardiology that with a cutoff value of 18, you can predict the risk of events, you can predict the risk to decide very quickly for a surgery for a patient that was asymptomatic a few weeks ago. So this is very important to add to LV ejection fraction GLS in our daily clinical practice, especially in asymptomatic severe aortic valve stenosis patients. So GLS is really ready for clinical practice, should be applied in our everyday practice because it's easy, robust, and it adds something to LV ejection fraction.
So lots of questions are coming up about strain and aortic stenosis, and they already came up after the last, the other study you presented about the ejection fraction. So how can we use it in in our clinical practice, the global longitudinal strain in aortic stenosis? So if you have a normal ejection fraction, let's say 60, and you have a decreased GLS, how can you consider that patient?
So if we have a patient who is clearly asymptomatic with a severe aortic valve stenosis and a preserved ejection fraction, the fact that GLS is low means that the risk of event is higher. So we can not yet send the patient to surgery just based on GLS, because we don't have the evidence for that. But we can be more careful, maybe assessing more frequently the patient, maybe using other parameters like BNP, like stress echo, to check for symptoms, to check for other parameters that are associated with the risk of event. So if you have a decrease in GLS, be careful, follow the patient very precisely to make sure that you don't miss the best timing to send the patient for surgery or TAVI.
Mm. Yeah, it seems very reasonable. We have lots of questions about cutoff values, and but here is one: can we consider TAVI in patients with, let's say, an aortic stenosis, severe, asymptomatic, ejection fraction of 55%, and a GLS of -17?
I can say what we do in France, because I only have
Sure.
my French experience.
Yeah.
In France, we can't implant a TAVI in an asymptomatic patient because of the cost. We have to wait for symptoms.
Oh.
So at least in France, we don't implant TAVI in asymptomatic patient. If it's about surgery, we can discuss perhaps, but I don't think that we have studies demonstrating that based on GLS, if we decide to treat the patient, we improve the prognosis. We just have studies demonstrating that GLS is associated with the prognosis, but we don't have the relationship between the risk and the treatment. So it's perhaps too early.
Yeah, I guess it's too early, but it's quite interesting, and I think the debate and discussion will go on for some years. So, but move on with your last part of your presentation, please.
Yes, thank you very much. And it's my pleasure now to discuss about innovations, because of course, during the EuroEcho-Imaging Congress, we have a lot about teaching, a lot about science, clinical science, but also we had the opportunity to have the high-tech corners with scientists, engineers coming to discuss with physicians about new things. So there are a lot of new indices, there are a lot of new parameters, there are a lot of new techniques that are coming up, and we might have to discuss some of them. First, we can discuss about myocardial work. This is quite interesting because it's very easy. You just have to measure the blood pressure, and thanks to an equation, we can compute both the longitudinal strain and the estimated LV pressure in a pressure strain curves. So we will have the pressure strain curves, and thanks to the pressure strain curves, we might be able to measure LV systolic function without being too embarrassed by the load, because we have the blood pressure that is an estimation of the LV pressure. So it's nice. And we have studies that have been done, and one of them has been presented at the EuroEcho-Imaging Congress. This is a study performed in Oslo, and it's about the importance of the septum in patients with left bundle branch block. Because you know that some patients with a left bundle branch block will develop heart failure and LV systolic dysfunction, and some other will have a left bundle branch block, but without any decrease in LV ejection fraction, maybe also without any symptoms of heart failure. And in that study, the authors looked at the septum and the septal work to understand why some have a decrease in LV ejection fraction and some don't have this decrease in LV ejection fraction. So they look at 25 non-ischemic left bundle branch block patients. They measure ejection fraction, of course, and they looked at the myocardial work calculated thanks to transthoracic echocardiography. And they were able to demonstrate one thing. There is a linear relationship between the septal work and the LV ejection fraction. And there is no relationship at all between the lateral wall of the LV work and the LV ejection fraction. So the septum seems to be fundamental to explain the degree of LV ejection fraction decrease in a patient with a left bundle branch block. And as you can see on that slide, you see the fact that the strain curve that you have in a patient with a decrease in LV ejection fraction within the septum is clearly abnormal, which is not necessarily the case in a patient with a left bundle branch block without any decrease in LV ejection fraction. And you can see very easily on the pressure strain curves how thick is the septum thanks to this non-invasive measure of myocardial work. So this is a nice study looking at regional strain, and it is interesting from a pathophysiological point of view, and it might be even more important if we can apply this result in patients treated by cardiac resynchronization therapy. Let's discuss now that study. This is a study about the prognostic value of myocardial work, and we were focusing in that study on the constructive work. We looked at a cohort of 166 CRT candidates. These patients were assessed before the implantation of the CRT device, and they were followed up to 5 years. And we looked for a strong endpoint, which is cardiac death. And of course, we had all the clinical, EKG, and echo parameters before the implantation of the CRT device. And in the multivariate analysis, you see that 2 parameters were associated with the risk of death in the multivariable analysis: the age and the constructive work. And we did a statistical analysis, we did the ROC curves, and we were able to come up with a cutoff value of 888 millimeters of mercury per percent to define 2 groups of patients according to their prognosis. And these 2 groups have clearly different prognosis. And it is even true when we looked at the constructive work prognostic value in patients according to the fact that they were or not responders to CRT according to the remodeling. So we have patients without any remodeling and a decrease in constructive work who have the worst prognosis, and we have the patient with a positive LV remodeling after CRT and the preserved constructive work who have the best prognosis. So this is nice to consider that myocardial work can be used to just look at the septum to best understand what's going on, but can also be used to assess the global left ventricle, and this is an interesting parameter to assess patients before CRT and to predict the risk of event in a cohort of heart failure patients. Let's discuss now about a very exciting field. This is the ultrafast ultrasound imaging techniques, because there are new things we can discuss about shear wave imaging, so trying to understand better the diastolic capabilities of the left ventricle. This is something that has been discussed already, and there are few studies available. And we have this abstract coming from Hong Kong demonstrating that with a new approach, they were able to get best images. I will just show you an example. Best images to assess the wall of the heart, but also the blood flow. So they were able to best quantify the blood flow, which is something that we cannot do nowadays. And they can also assess very precisely the myocardial motion thanks to these ultra-fast imaging techniques. So this is something very exciting to best assess systole, blood flow, and perhaps also diastole. And just to finish this presentation, I want just to show you an example about machine learning, because machine learning is very hot nowadays in imaging, in CMR, but also in echo. This is a quite small study, but quite interesting, looking at patients suspect to have a heart failure with preserved ejection fraction, and these patients were assessed by echo at rest and during exercise. And the authors looked at demonstrating which is the best parameter to define the patient with a heart failure with preserved ejection fraction versus the patient without any heart failure with preserved ejection fraction. They look at strain and they look at strain rate. They had 100 subjects. They did the diastolic stress test. They did the machine learning framework. They were very precise to ask the computer to decide which is the best parameter to define patient with heart failure with preserved ejection fraction or not. And they come up with the fact that in their approach, the strain rate, the longitudinal strain rate, was much more powerful to define patient with heart failure with preserved ejection fraction than the longitudinal strain. So this is quite interesting to know that thanks to the machine learning approach, we can best define the parameters that are the most useful to make a diagnosis and to define a subgroup of patients. Thank you very much.
Thank you, Erwan. People were quite interested also in machine learning. So here is one thinking about his or her future. And the question is, do you think artificial intelligence or machine learning will replace humans as echo interpreters?
I don't think so.
Why not? Why not?
Because we are better than computers. No, but it might help us to be more efficient, because thanks to the machine learning, thanks to the artificial intelligence, we can easily select which exams are normal, which exams are abnormals, and in the abnormal subgroup, then we might have the need to integrate the imaging aspects, the clinical aspects, and never forget that we are interested in echo, CMR, nuclear imaging, and CT, but we are cardiologists and clinicians first, and then we use echo as a tool, not as an objective.
But do you think it can replace CMR and CT?
For CMR and CT, it might be interesting because the image quality is a bit better than in echo, and it's easier to apply machine learning. So it might decrease the need for physicians to measure everything.
Yeah, the measurements can
be easily done. Yes.
Yeah.
But still, we need experts who can manage all the data that the computer will provide to us.
And here we have time for another one. What about GLS with CMR?
GLS with CMR, it's interesting to see that the results that are obtained by CMR are quite the same that the one that we have in echo. So it might be very useful when a patient is not suitable for echo. But I think that we have to be reasonable, and CMR is not a technique that we use as a first imaging techniques. We first use echo, and then if we need, we do a CMR, because we have a lot of expectation for CMR, but not for everybody. So we start with echo. If we cannot get everything that we need with echo, we do a CMR, and we can get GLS by CMR, which is nice.
Yeah, so if you have really low resolution or really low quality of echo, then you can jump to CMR and have almost the same results. Well, in my opinion, it's a little bit lower, the GLS values in CMR, but it has to be decided, of course. Okay, we have many more, but we can try to go through them and answer on the web, because there were really many questions coming up from all over the world, actually, so it was quite interesting. But I don't think we will do more now. So we will now close the webinar. Thank you to Professor Erwan for his presentation on the highlights from EuroEcho-Imaging 2018. You will all be able to view again this webinar offline in a few days on the EAC website. And remember, please, the EACVI has 3 great imaging conferences coming up in 2019. We have the EuroCMR 2019, we have the ICNIC, and we have the EuroEcho 2019 in Vienna in December. Thank you to all.